ECMO neuromonitoring.
Good evening, Pranay, Ram, and everyone. Can you hear me?
Yes, sir, we can hear you.
So, I will deal with the very important aspect of neuro monitoring and ECMO. I have no disclosures at this point. The objectives of this talk are why the brain is important in neuro monitoring on ECMO and why it is taken as the very selective criteria to decide about the success of ECMO. What is the difficulty in assessing neurological criteria while on ECMO? How do we do this neuro monitoring? That is the clinical monitoring mainly. And what is the interpretation of imaging and other modalities? What can we do if things go wrong? I will try to cover it in the next 20 minutes. As we all know, brain is the most important organ for all of us. It is a key factor in accepting a patient for ECMO. If there is already a pre-existing intracerebral bleed, intraventricular bleed, you don't want to take the patient and put them on a mechanism like anticoagulation is the keystone in managing this process of ECMO. So you will be very choosy in selecting a patient who hasn't got an intracerebral insult. Similarly, it decides the course of ECMO as well. So whenever during the course of ECMO, if you happen to come up with an intracerebral bleed, then you have to think twice: should I continue or should I stop at this stage, irrespective of the outcome of the patient. So this way, brain decides. This is the most important organ for the success of ECMO. It is uh, very much proven all the patients do not bleed into the brain. Most of them will come out, but those factors which lead them to bleed into the brain are pre-existing ischemic area. If there is an ischemic area associated with hypoxia and hypotension, that is the nidus into which a patient is likely to bleed. Systemic heparinization only adds to that, but the most important is the pre-setting of ischemia. Impairment of cerebral autoregulation might contribute to that as well. More studies are going on in this direction. It is still at a research phase at this time. Hopefully, we will have further recommendations about how can we adjust with this impairment of cerebral autoregulation. No doubt there will be microthrombi, microemboli during the process of ECMO. It is next to impossible to do ECMO without any microemboli or microthrombi. So, if there is a ventricular septal defect or some sort of communication between the atrial chambers or ventricular chambers, these clots are likely, or even a PDA, these clots are likely to pass on to the systemic circulation and thereby to the cerebral circulation. Effect of carotid ligation or reconstruction in small babies, it also may have an impact on it. The difficulty is all these patients will be on sedatives, paralytic agents, so it will be difficult for us to ascertain the consciousness, GCS scores, and the extent to which they can move their hands or feet. Need for readily available dynamic tests is very much needed without involving assessment of the tone, for example. Transporting the patient with ECMO cannulae and pump is not easy from place to place. Like if you want to take the patient to CT scan when you suspect some neurological abnormality before going on to ECMO, it might be difficult sometimes because the patient is critically unwell, collapsing, and you want to do a CT scan to find out the neurological condition from structural integrity part of it. So, physiological closure of a window such as anterior fontanelle in infancy may help if there is a significant bleed. Fullness of the anterior fontanelle to bulging of the anterior fontanelle can be seen. Despite the risk of over or under cerebral perfusion, ECMO protocols are based on systemic rather than brain specific parameters. We always look at what are the lactate levels, what are saturations, these sort of surrogates rather than looking at cerebral perfusion markers for continuing the course of ECMO. So this leaves brain at the risk of injury. The complications which are noted and everyone needs to note for the ELSO point of view is also like this bleeding into the brain, ischemia, seizure activity, hemorrhage, stroke, and brain death. These are the essential criteria everyone is supposed to note for every patient who goes on to ECMO. In the ELSO registry, and data set do exist, and this is compilation of the results. And to the right side, you can see the percentage survived, percentage reported, percentage survived here to the right side here. Seizures, diffuse ischemia, hemorrhage, intraventricular hemorrhage, neurosurgical interventions, etc. So this is again a summation of the data with the neurological complications for patients on ECMO till 2021, intra or extraparenchymal CNS hemorrhage in various age groups in neonatal, pediatric, and adult age groups. So these are international data you can obtain from ELSO registry. And people have tried multimodal invasive neuromonitoring in adults undergoing ECMO, which is uh, proven to be better monitor compared to a single monitor here. What I am talking about here is like a combination of diffuse correlation spectrometry, transcranial Doppler ultrasound, EEG, auditory brainstem responses, and cerebral auto regulation metrics, etc. So, a combination of these measures will give a better understanding of the neurological health during ECMO than one or two monitors. It involves a practicality also, I understand. The phases of the neuromonitoring are pre-ECMO. This is at the time of selection of the patient for putting onto ECMO. You ask about history of seizures and stroke, cerebral ischemia, hemorrhage, etc. before putting onto ECMO. Sometimes and ideally, you can ascertain by running the patient through a quick CT scan, but it would be very difficult before going on to ECMO in adults because of the critical nature of their illness at that point of time. If they are crashing, they cannot tolerate a half an hour ride to radiology department and to come back again. In neonates, probably it would be helpful because ultrasound is a bedside tool which is available, and you can have reasonable information from doing the ultrasound as long as the anterior fontanelle is open. Post ECMO, these methodologies are available for us doing a CT scan, MRI scan for having a detailed look of the brain structure and neuropsychological evaluation also. The monitoring is clinical monitoring is extremely essential. Daily frequent assessment of the neurological status, just like we do for any other patient. GCS, um, we need not continue sedation all the time. You have to wake up the patient, see how they are responding, giving importance to analgesia, and at that time you can assess GCS status at that time. Pupillary examination is very important. The size of the pupils, if the pupils are unequal, that gives more important information about something happening within the brain. Mobility of the patients, neurodeficits, seizures, and other gadgets that we can use on them. So, with respect to the pupils, changes in the size, equality, and reactivity of the pupils is important. Dynamic pupillometry gives several objective biomarkers. Unreactive pupils can be caused by an expanding mass, such as a blood clot, exerting pressure on the oculomotor nerve. So, that is the importance of the unreactive pupils. Unilaterally fixed and dilated pupil. Uh, Pupillary dilatation is a very important marker for you to think there is something uh, happening in the brain, but it is not the ultimate. Despite the presence of bilateral pupillary dilatation to size 5, still intracranially CT scan may come out to be normal as well. So it is a good marker. At the same time, there are fallacies also with that. It is not 100% right, and it cannot be always associated with pupillary dilatation is equivalent to brain death. No, there is no equation with regards to that. Check if there are any pre-existing factors such as cataracts or pre-existing eye surgical issues, those that can cause pupillary dilatation or contraction, constriction, or existing like medications which might have used, or some long-acting anticonvulsant medications also can produce changes on the pupils also. New onset changes are more important as a screening test, and damage anywhere along its route can result in the abnormal static and dynamic pupillary responsibility. Certain devices are available for us. This is about the um, light reflex, and when you find abnormality, the problem could be anywhere along this um, light reflex pathway. Pupillary pupillometer. This is the device available for us for exactly measuring the size of the pupil. So it will tell us what is happening with the pupils, and very important tool to have if it is available for you. Electroencephalography, all of us have used it. It is either static or a continuous electroencephalogram, is a bedside tool too. EEG measures the cortical activity through a series of electrodes attached to the patient's scalp. The beauty of it is because of the multiple electrodes covering the scalp, or most of the scalp, so you can also pinpoint where the problem is and deal accordingly. Alpha to delta ratios can be calculated from the alpha and delta waves on it. People with neurological injuries also are seen to have a lower alpha delta ratio value compared to those without injury. So this is a typical EEG, how it looks like, and the localization. You can also see the erratic waveform going up and down in case of seizure activity, active seizure activity happening. And we know about the amplitude of the brain waves also when there is brain death. This is CFAM, cerebral function analyzing monitor. In children, neonate, we tend to use it a lot. It gives it gives the information available for only 4 electrodes, not like 16 or 18 electrodes we use for EEG. It's a miniaturized version. Only 3 or 4 electrodes can be used in this. So um, in the bottom part of the screen, you are seeing the upstrokes and coming down here in the first bit you can see this could be a seizure pattern, or when there is an electrical interference by touching it, or any electric by sound vibrations also something happening, or you are suctioning the patient also, these sort of waveforms can be seen on it. So you are supposed to write down what sort of activity, external activity is responsible if something is happening there. If not, that is reflective of something abnormal. In the bottom part of the screen, you are seeing here a wider spectrum of the recording which is abnormal here. So that shows something has been happening there, such as seizure activity. So this is the generalized wave pattern. Generally, it is like a band, midway band. This is a healthy pattern here, around 25 microvolts or 50 microvolts. That is a healthy pattern. When it is towards 0 microvolts or between 0 to 5 microvolts, that is very depressed pattern of the CFAM. Then you can go for subsequent tests such as EEG. This also is a widening of the uh, pattern. These patterns anybody can be trained to know, to understand and analyze also. So it is a easy tool available bedside. See, this is the isoelectric voltage, very low voltage, as I mentioned earlier, between 0 to 2, 0 to 3 in that waveform. That is a very low voltage, synonymous with brain death. So next is about ultrasound in neonates. It is a very valuable tool as long as the anterior fontanelle is open. It allows a detailed and comprehensive examination of the brain parenchyma. In expert hands, it almost equates with CT scan examination as well. As some of these studies, like by Bulas et al., they have shown sonography identified 46 out of 49 major intracranial hemorrhages. It might not be able to pick up the minor ones, but the major ones it should be able to pick up. It's an easy, accessible, low cost, portable tool available bedside, and there are no ionizing radiations here. You can repeat it any number of times you would like to see. So on daily basis, neonates should have ultrasound examination of their brain. Beware of choroid plexus, that is a collection of the blood as well, which is normal structure. So you shouldn't mistake it for presence of intraventricular bleed. Isolated subepidermal hemorrhages, they don't matter. Daily sonograms are recommended. If the intraventricular hemorrhage is of more than grade 2, then it becomes a contraindication for going on to ECMO. For grade 1 and grade 2, still ECMO is accepted if it is needed. Cranial ultrasound scans. It is a normal cranial ultrasound scan, and within the brain, you are within the ventricular system. You can see the posterior choroid plexus, which is opaque structure within that is normal, completely normal. Brainstem auditory responses, they are quite useful as well for predicting what is happening within the brain. Uh, these EP measurements such as brainstem audiometry responses can provide information on the subcortical health. For example, injury to the specific regions of the auditory pathway such as brainstem can be determined by abnormal latency of the BERA or auditory brainstem responses. Patients who suffered from neurological injury showed delayed latencies of specific waveforms or no waveforms in response to auditory stimuli. So, this would be quite useful in unresponsive patients. Diffuse correlation spectrometry. In studies, it was shown to be very useful again. It uses the interaction between light and moving scatterers, like RBC, in the cortical microvasculature to obtain cerebral blood flow as a surrogate of surrogate. It's called as blood flow index, BFI. It is a surrogate of the cerebral blood flow. It is a very useful tool to have in ICU, especially for the sake of neuromonitoring. It is a desirable tool, but not a must. Transcranial Doppler, uh, majority of us in the ICUs do have transcranial Doppler. It measures the cerebral blood flow velocity of deep cerebral arteries. Cerebral blood flow velocity from transcranial Doppler and blood flow index together, they have very good correlation as well. Near infrared spectroscopy is a tool many of the intensive care units started using in the last 5 years in India. Near infrared spectroscopy is a reflection of global brain oxygenation. Um, there are uh, these electrodes which go onto the brain. Like two of these electrodes can be placed on the brain, on the skull, and two will go for somatic saturation recording in the region of the kidneys. So two electrodes will record it from the kidneys. Somatic is for yes, and left and right hemispheres here. Left reading 65, right reading 67 as you're reading here. In this case, somatic saturations are less, 70, 79, and so are the uh, cerebral saturations as well. The extraction is less here, but the Systemic oxygenation is also less in this particular case. It helps by injecting photons into the area underneath skull vault. So these electrodes emitted photons, they are picked up by the electrodes on either side, the optodes mentioned here, and from there it will be going to the console, and the data analyzer monitors it and gives the numbers for you. It works by injecting light photons into the overlying skin and then scatter inside the scalp, brain, and brain tissue. A fraction of the photons, referred as reflectance, returns and exits the skin. Reflectance is then picked up by two photosensitive diodes. So, low NIRS index has been associated with the cerebral dysfunction in cardiac patients with an index of less than 50, or index of more than 20% decrease from the baseline. So this is a baby here with a NIRS electrode on one side of the scalp here. There will be another one on the other side, and two over the region of the kidneys for somatic saturation recording here. This is how it looks like. So showing you how much area it can pick up underneath the scalp. And these two readings here are showing the K is for this is a systemic saturations of 92, and the or both somatic or systemic saturations of 92 and cerebral saturations of 89. It is only applied on the right side here. So alternatively on the other side, 43 and 43. So 43 to 43 are saying the somatic saturations as well as cerebral saturations both are low. Whereas on the other side, the first picture, somatic saturations are good up to 92%, and brain is not extracting much. It is showing 89, which is close to a figure of 90 as well. Generally, that should be two-thirds. So, near infrared spectroscopy is a useful tool. Unlike pulse oximetry, it doesn't depend on the pulse pressure and no temperature variations as well with it. NIRS can be used prior to going on to ECMO, during cannulation, and during trial of ECMO as well. It is also able to read at extremely low values and not a cutoff value at less than 35% as the case of saturations. Additionally, unlike saturation recording, it is a measure of regional oxygen saturation also. And there is growing data. More data is available now in the interpretation of the NIRS. This is one paper talking about the regional cerebral oxygenation measured by multi-channel near infrared spectroscopy in an infant supported on VA ECMO, how it is used and how effective it is. CT scans are useful tools um, in neonates. Once you diagnose something, some major bleed happening inside or a bleed in the brain, then as these patients are reasonably stable for transporting to the radiology department and bringing them, CT scans can be done in those. Similarly, every ICU catering for ECMO should go through the procedures of transferring their patients to the radiology on ECMO circuits and get the CT scan done and come back. Simulations can be done in making it happen in a faithful manner. So, in a hazardless circumstance, it should happen. So, preparation is needed for carrying our patients, transporting our patients from the ICU to CT scanner and bringing them back again. So it is very important for every ICU to go through this process. Personnel are important. Planning and execution is important as well for successful uh, outcome. At least to know what is happening inside. The problems could be hemorrhagic stroke and post evaluation. In this case, also you're seeing there is a hemorrhage adjacent to the ventricles over there. Seizures on ECMO due to thromboembolic or bleeding events, this can happen. The management is important, and is anticoagulant, anticonvulsants, like we try in any other case. Conventional management, clinically diagnosed. Once you happen to see seizures in any patient have a high suspicion if they recur again. Ideally, paralysis should be avoided in these patients. Clinically diagnosed and EEG would be helpful as well. We discussed about CFAM already, and continuous EEG can tell us about what is happening over a period of time. Subtle seizures can be picked up on continuous EEG too. Stroke on ECMO can happen. Secondary to thromboembolic events are rapid changes within the PaCO2. Hence, drastic reduction in the carbon dioxide should not be done. Only gradual reduction should be done. Hemodynamic instability or shock in these conditions also, stroke can happen. So when it happens, monitor the patient. TCD can be helpful for further examination. Cerebral near infrared spectroscopy can tell you about the regional saturation of oxygen in the brain tissue, and the hemodynamics have to be maintained as well for the cerebral perfusion pressure. Optimal transfusion requirement is not yet determined. Um, Provision of supplemental oxygen, cardiac monitoring for arrhythmias, addressing the cause for it, keep normoglycemia, pneumatic compression devices for preventing DVT, early mobilization if it is possible for prevention. Mechanical intravascular or neurosurgical intervention is available these days for thrombectomy in selective patients. So if you have skilled interventional neuroradiologists or neurosurgeons, you can always talk to them regarding the management and make it an MDT decision. So in such cases, if it is a major bleed, you have two options: either to come off ECMO because continuing on anticoagulation mechanism for longer period of time might result in extending the clot further, which is not in the best interest of the patient. So you tend to stop it and see if you can manage the patient conservatively with ventilation itself. Or the second possibility is continue on ECMO without heparin and see high flow ECMO without heparin and see what is happening to the clot, what is happening to the patient status as such. That is one way you can manage it. Heparin free ECMO is a possibility if there is a significant intracerebral bleed and still there is no recovery of the lungs for managing the patients by coming off ECMO. Neurointerventional technologists are increasingly using imaging rather than time to determine the candidacy for intervention. So that is something worthwhile to consider. Hemorrhage on ECMO can happen. Similar principles of management. Monitor the ACT, APTT, anti-factor 10A assay, thromboelastography, etc. Try to correct these abnormalities if they are grossly abnormal. The mortality of intracranial hemorrhage in ECMO patients is around 80 to 90% as per ELSO registry data. So that is something not very welcoming. It depends on the extent of intracerebral bleed also. In newborns, it can look like this. There is a drastic intraventricular bleed. More and more evidence is now available on cerebral autoregulation in ECMO patients. This is from the studies of one of my colleagues, Dr. Lakshmi Raman from Dallas Children's Hospital. It is in the research phase at this point of time. Hopefully, in future we will have more information on cerebral autoregulation alterations resulting in intracerebral bleeds. So when patient has any of these complications comes out and you can successfully manage them to come off ECMO, then neurodevelopmental clinics are a must for them for following up. Intervention of a neurologist, psychologist, and a neuro rehabilitation team is very important for monitoring them. Relevant scans such as CT scan, MRI scan, PET, SPECT scans, etc. They should be done. CT is useful for identifying infarcts, diffuse edema, and atrophy. MRI gives much greater range of Soft tissue contrast depicts anatomy in greater detail. SPECT scan, it predicts normal outcome, but abnormal PET scan doesn't predict abnormal outcome. So the take home message is neurological monitoring and ECMO is an essential tool at all age groups. Clinical monitoring is extremely important, as well as the supportive tools. I mentioned a variety of supportive tools here. It is not a must to have all of them, but the more you have, the better it is. Transport for CT scan involves operational challenges. Preparation is the key, and every ICU having ECMO should go through this. Cerebral auto-regulation on ECMO is being evaluated. It might give us more knowledge and thoughts about preventing intracerebral catastrophes on ECMO patients, and follow up is mandatory in these patients. So, if there are any questions,